looks like we're starting to get to about the numbers of panelists that we normally have. So to avoid going over, I will get us started today. So thank you everybody for joining us for the April edition of the Neonatal Hemodynamics Targeted Neonatal Echocardiography and Neonatologist Performed Echocardiography Foundations curriculum. Just a quick reminder of kind of the things that we say each time. Those of you that are panelists, you guys have been identified as hemodynamics, either trainees or junior faculty. And so you do have the ability to unmute yourself and turn your video on. I do ask that all of you make sure that you're muted for the talk and only unmute yourself when you are wanting to ask a question. This session is recorded, and so if there is discussion within the lecture time period, that will be on the recording. However, at the end of the recording, we will stop, and the Q&A session that's scheduled for after the lecture will not be recorded. And the lecture will be on our YouTube channel soon after this. For those of you that are just the webinar participants, please, we do want you to participate as well and to ask your questions. We do get some great questions from the audience. However, we will take priority to our trainee questions. So if those don't get answered, that is usually the reason why. But please remember to put your questions into the Q&A box, not the chat box. Sometimes the chat box gets utilized a lot and we can lose those questions. So the Q&A, which is right next to the chat box, please put those questions in there. We do have a session evaluation with the QR code. I will put this up again at the end of the session for you to grab so that you can fill out the evaluation. We do listen to those and we do make changes based on those suggestions. So please make sure that you do your evaluations. And so without further ado, let me introduce our speaker for this session. Dr. Joseph Ting is an associate professor in the Division of Neonatal Perinatal Care at the University of Alberta and staff neonatologist at Stollery Children's Hospital. He completed his residency in pediatrics, his postgraduate diploma in infectious diseases, and Master of Public Health in Medical Statistics, all from the University of Hong Kong, and was trained in T&E at the Hospital for Sick Children in Toronto. His research interests include neonatal infections and antimicrobial stewardship and neonatal hemodynamics in T&E. So he is going to be talking to us today about the hemodynamics of septic shock. And then a reminder that our next lecture is in May, and that will be on ecmophysiology, and we hope to see you then too. But let's get started. Joseph, I am going to stop sharing my screen and hand it on over to you.
Okay. Thank you. Thanks, Laura, and thanks for the group for the invite. So let me share the screen. Can people hear me well?
Yes, we can.
Okay, excellent. Yeah, let me share the screen. Okay, can we see the slideshow well?
Yes.
Yep.
Okay, so today my talk is about the neonatal septic shock. I don't have any financial relationship to disclose or conflicts of interest to declare. I am grateful to my teachers in pediatric cardiology back in Hong Kong, as well as my teachers of the T&E faculty at the University of Toronto. I've been in Canada for almost 10 years. So what I'm going to do today is I'm going to bring up two scenarios that many of us have encountered them at the NICU. I'll talk about the classification pathophysiology of neonatal septic shock. And we are going to do how are we going to approach, assess, and do the diagnostic evaluation. Last but not the least, of course, is talk about the management based on the pathophysiology. Scenario one is so there's a female infant born at 27 weeks, 920 grams. Mom received steroids and her membranes ruptured at delivery. Initial stabilizations, her initial stabilization include NIPPV, UV, TPN, antibiotics, and initial sepsis screen negative, and antibiotics stop at 36 hours. Feeding well, and then lines were removed. On day 28, the baby's clinical condition worsened, and at 3 a.m., it always happens at 3 a.m., the baby became lethargic, hypothermic, apnea, increased oxygen requirement, very distant abdomen, heart rate 185, the blood pressure, systolic blood pressure 45, diastolic blood pressure 18. Clinically, it's well perfused. Abdominal X-ray, you see portovenous gas, pneumatosis intestine. That is, so you reintubate the baby, sepsis evaluation, antibiotics. So what would you do next? So I give you some answers. I'm not able to do any poll here, but like I just put up some of the potential solutions. Normal saline, maybe you like to give some bolus resuscitation. Maybe you like to start some dopamine, epinephrine, norepi, dobute, mirinone, hydrocortisone, PG, or because after you intubate, you found the FL2 was 80%, you like to start the nitric oxide right away. Or I don't know. So what will be your response? Think about that. I'll give you 5 seconds to think about that. So these are the, yeah, what would you do? So the team put in the normal saline. The baby is kind of like responding a little bit. Systolic blood pressure go to 50, diastolic 20, heart rate 175, drop from 180 to 175. FL2 50% is not that bad, like PIP 25, PEP 8. So it's very lucky they have someone who's do the TN echo on the night shift. They found the fracture shortening of LV was robust 45. LVO was 330. The ventricles look very underfilled, RVO 300. Doppler over the mitral valve, E ratio 0.7, IVRT 55 milliseconds. Tiny PDA, tiny PFO, probably left to right shunting. Run interventricular septum on the parasternal short axis view, which basically speaks against any significant pulmonary hypertension. So what would you do next? Are you going to change your mind in terms of what you have done? So as promised, I give you 5 seconds to think about that. I cannot see your answers on the chat box, but it's okay. Scenario 2. So is a baby like born at 24 weeks, 600 gram, P-prom, GPS status unknown. After birth, like intubate with the 2 doses of the, sorry for the typo. I don't know why, like intubate with 2 doses of surfactant, UAU replacement, TPN, antibiotics. Initial sepsis screening negative, antibiotics stop at 36 hours. So in that unit, they like to give the prophylactic indomethacin. So on day 3, the baby's clinical condition worsened, FL to 100%, motile, poorly perfused, lethargic, hypothermic, very distant abdomen. So people think of like quote unquote warm shock in the last scenario, but right now you have a very motile, very badly perfused scenario. Heart rate 165, systolic is 35, diastolic blood pressure is 15. X-ray shows classical RDS. Type of the picture have not completely resolved, not surprised. The lung actually didn't look back at all to explain the FL2 of 100%. Abdominal X-ray shows a couple of segments of those bowel. You worry about the SIP, but there's no evidence of pneumoperitoneum to suggest spontaneous intestinal perforation. Of course, almost the knee-jerk response from our neonatal colleagues will repeat the sepsis evaluation, start the antibiotics. So at this point, what are you going to do from the hemodynamic perspective? Which medications or which actions you are going to take? Again, I give you 5 seconds to think about that. Okay, 5 seconds is up. So somehow someone doing TNE was called urgently back to the hospital, and then do the TNE. The LV fraction shortening is 25%, LVO is 50 mils per kilo per minute. RVO was 60. So very dilated RV, compressing the LV, some tricuspid regurgitations, Doppler EA ratio 0.6, IVRT 55, PDA. Oh, PDA, there's no ductal flow. Careful, they couldn't see any flow across it. Some paradoxical septal motion and systole. So I use this kind of like these pictures from one of the reference, but this is not the actual picture, but like of that patient. But you see the dilated RV bulging into the LV is kind of like paradoxical septal motion and systole. So while the sonographer, not the neonatologist, is doing the echo, at the same time, like oh, he got the information subsequently that like the blood culture was like found to have an E. coli, presumably. So what would you do? So what would you do? PPH, presumably high pulmonary pressure, poor contractility, poor cardiac output. You start the dopamine to improve the blood pressure, start some Mirinone, start some PGE, start the nitric, or I don't know. So again, I'm not able to see your answers. Think about that. These are all the answers that are possible. So going back to what we know, and neonatal sepsis actually has changed a lot in the past 20, 30 years. If you're interested in reading those neonatal literature, in the old days, people always worry about GBS, and GBS. So right now, especially for those early onset sepsis, GBS is not the top pathogen. The top pathogen is E. coli in preterm infants, while the GBS is still the top pathogens in term infants. And people have been concerned about the So the people have been concerned about the emergence of the resistance among the E. coli in both early onset sepsis or those like late onset sepsis. Late onset sepsis rate, I copied this from the Canadian Neonatal Network annual report. You can see that among those like born at less than 26 weeks, less than 27 weeks, at least a quarter to almost like 1/3 of them, more than 1/3 of them will have at least an episode of the culture-proven sepsis during their stay. So this is something that is quite important, but bear in mind in Canadian Neonatal Network, the definitions are a little bit different from those CDC. They need only one blood culture and also the relevant symptoms and the infants being treated for 5 days of antibiotics. So these numbers may be higher than the numbers reported by our colleagues who are following the neonatal research network definitions. So going back, we talk about the neonatal sepsis. We talk about some true scenarios that we are seeing every day. Not every day, I exaggerate, but like when we are on call, and look at some very kind of like crude microbiology. So then goes back to the fundamental question: what is neonatal sepsis? What are we talking about? So this is a complicated slide I copied from the New England Journal of Medicine. Essentially, the sepsis by itself, that frequently it may not be the bacteria who is causing the trouble, but it is the host response. So essentially, the host response to sepsis is characterized by both what we call pro-inflammatory and also the anti-inflammatory immunosuppressive response. So the pro-inflammatory response initiated by some interactions between the pathogens as well as the pathogens, the host cells, and afterwards there will be some that expressed by the host cells at the surface, such as those are what we call the toll-like receptors or C-type lectin receptors. So the consequence of this exaggerated information is collateral tissue damage, necrosis, cell death, and there will also be mediated a whole bunch of those series of reactions, like those what we call kind of like leaking type of in our microcirculation. On the other hand, is this kind of like exaggerated informations by itself, it may also actually is like causing troubles that have some impact on both the adrenal cells, neuroendocrine regulations, and it affects the productions of the cortisol. It may also cause immunosuppression, which enhance susceptibility to further infections. So shock. So I try to copy this from some of those standard texts. People are talking about shock all the time, but like the word of shock may mean different things in different people's mindset. So shock essentially is a state of cellular and tissue hypoxia due to reduced oxygen delivery, increased oxygen consumption, and also oxygen utilization. So basically, less oxygen delivered, the cells are not able to use the oxygens. And as a result of the hypoxia, the cells will switch to the anaerobic metabolism. There will be accumulation of lactic acid. So that's where we found in terms of we measure the serum acids. When there's increased lactate, we say, oh gosh, like the perfusion may not be good. This is because the cells turn into anaerobic mechanisms. Excuse me. So increased level of lactic acid will cause metabolic acidosis, which will interfere the cell organ functions. And such tissue hypoperfusion may also trigger endothelial dysfunction, stimulation of those inflammatory anti-inflammatory cascades that I mentioned in my previous slide, activation of the process, humoral neuroendocrine process, which disrupt the microcirculations, affect the cortisol response, resulting in further tissue injury. In the classical teaching, we always talk about warm shock and cold shock. So warm shock essentially like there's a reduced systemic vascular resistance, increased cardiac output, vasodilatation. Feel the baby looks really well perfused, tachycardic. Cold shock, peripheral vasoconstrictions to maintain the blood pressure, increased systemic vascular resistance, cold and marbled ends, mottle, delayed refilled, oliguria. So these are the classical descriptions, but the life is not that simple. So if you go back to some pathophysiology mechanisms of the possible differential, cause of the shock, strictly speaking, you can find basically 4 categories of shock. One is hypovolemic, one is distributive, one is cardiogenic, one is obstructive, and even more often it is multifactorial. It's a mix of these 4 categories. So hypovolemic shock in neonates, why do I have to talk about hypovolemic shock in the setting of the neonatal septic shock? The reason is that for those preterm neonates, when they're in the especially those with early onset sepsis, of sudden the baby may have query septic shock. We are already given broad spectrum antibiotics within the first hours of life. However, the baby may deteriorate suddenly at 12 to 24 hours of life because of active breathing. And then you put the ultrasound probe on the head and you find that there's a grade 3, grade 4 IVH. So this will sometimes lead to the hypovolemic shock. If you only give the vasopressor, it's not going to work. Don't forget, in those extremely preterm infants, especially those 24, 25, 26 weeks, or those SGA infants, they may have the frank diuresis when they're recovering from acute kidney injury, whether it is in utero, postnatal, sometimes you never know. And they have, because of the very poor tubular functions, the babies can pee into the state of even hypotension. First spacing is pretty common. Acute intestinal injury, like a scenario 1, the baby may have a frank necrotizing enterocolitis, or even sepsis due to whatever reasons. There will be ileus, and there will be tons of first spacing in the intestinal tract. As a result, there will be decreased intravascular volume. This is what we call third spacing. So these are the phenomena of the hypovolemic shock. I try to stay away from the talking about those different intracranial subgaleal hemorrhage, but these are some of the scenarios that we commonly encounter in those preterm infants. Distributive shock. We talk about the reduced systemic vascular resistance, abnormal vascular tone because of maldistribution of blood flow within the microcirculations, resulting in the hypoperfusions. Common examples that I have illustrated in the scenario 1 is when the baby's got sepsis, there will be tons of the vasoactive mediators that may depress the autonomic nervous system, affect the systemic circulations, diffuse vasodilatations. We feel the baby looks warm, looks nice, but actually the tissue perfusions are compromised. And to further complicate the stuff, that not infrequently, these babies may have relative adrenal insufficiency because of prematurity, or because of the part of the inflammatory cascade. They will be impaired adrenocortical hormones released at the cell release as well. So this will also affect the vasomotor tone. So this will cause distributive shock. Cardiogenic shock, so myocardial dysfunction is not uncommon. So the common scenario is like, for example, with the sepsis, for those infants with like the frank sepsis, those like endotoxins, they may have some negative impact on the myocardial contractility. And sometimes these infants may also be complicated with the chronic fetal hypoxemia in the SGA infants where they may have relatively low reserve. Transitions may be delayed, which may or may not be related to sepsis. Anyway, with all this coming together, the myocardial injury dysfunctions may be related to the sepsis, may be related to the complications such as PPHN. The frank result is myocardial dysfunction. So in those cases, just use the high dose vasopressor is not going to work. To complicate the stuff, sometimes we worry about the sepsis, but sometimes, especially those left outflow tract obstructions with the PDA closure, they can be mimickers of the neonatal sepsis. While hypoplastic left heart syndrome should be readily diagnosed, like in during the antenatal period, sometimes the coarctation or interrupt aortic arch, they may not be readily picked up in all the antenatal ultrasounds. And then with some kind of like some other pathologies, those are supersystemic, what we call RV-dependent systemic circulations with the RV failure because of the sepsis, because of the supersystemic PPHN, or even sometimes with vein of Galen malformations. And with the PDA closure, the baby can crash in front of you. And it could be due to underlying sepsis. It could be due to something else, but it could be all can be great mimickers of the sepsis. So myocardial function dysfunction leading to cardiogenic shock is something that we need to bear in mind. Obstructive shocks, hopefully it will be readily diagnosed because of the frank pneumothorax, cardiac tamponade, like the other mediastinomas, they are pretty rare, but pneumothorax, cardiac tamponade is something that we need to really consider when there is kind of like shocky status, because sometimes you fix the tension pneumothorax, the things can change dramatically. Multifactorial shock. So sepsis sometimes can give, as I illustrate in both cases, it can be distributive shock, it can be cardiogenic shock, and it can also be hypovolemic shock because of the third spacing, distributive shock related to sepsis by itself. Cardiogenic shock can be related to sepsis by itself or frank PPHN causing the RV failure and then biventricular dysfunction. Severe intestinal injuries, for example, relate to the NEC. Of course, there will be hypovolemic shock due to the third spacing, but with the ongoing inflammation process, there will be distributive shock as well. For those infants with the sepsis, it's not uncommon for them to have the frank pulmonary hypertension, which may result in functional pulmonary atresia, right ventricular or biventricular functions, which will result in some kind of like cardiogenic shock. So, I mean, warm shock, cold shock, these are the classical teachings. They're very important for us to recognize. However, life is not that simple. I illustrate about the hypovolemic, cardiogenic, distributive, obstructive shock. And in the real life, it is not infrequent, it's a mix of this type of the shock. And then to further complicate it, this lack of the evidence-based treatment in lots of common scenarios. For example, like when you talk about definition of septic shock, do the literature use the same definitions? The problem is we don't have a unified definition of septic shock. In a lot of those literature, where they compare different type of treatments, they also use the clinical sepsis included in the septic shock. So what does clinical sepsis mean? It means a lot of things. Studies, they may use different types of the outcomes, 7-day mortality, 14-day mortality, neonatal mortality, BPD, blah, blah, blah. So it's very difficult to understand, to compare directly the findings of different studies, and many of them do not have a detailed illustration of individual pathophysiology. So I'm trying to confuse you by one of the very great publications in the pediatric research in year 2024. I just found it this morning. So this is a great kind of like I really like this this review article. Summarize those prospective clinical studies looking at the echo findings related to the septic shock. So most of these studies, they include 20, 30, 40, or maybe some 60 infants with some culture positive septic shock, or some with some match control with something, and they're kind of like, what they have found is that elevated cardiac output with low systemic vascular resistance consistent with warm shock, food responsive low preload status in the sepsis, or like infants with the sepsis may be at increased risk of acute pulmonary hypertension. Another 6 studies here, global cardiac dysfunction reduced in sepsis. They may be LV systolic dysfunctions, maybe a feature of the sepsis. So what I'm trying to say is that I'm here to confuse you because there are lots of studies, but many of these studies, they only include a small number of the patients. And then in the subsequent slide, I also always tell you, I'm going to tell you that some of these kind of like, a lot of those studies, they are from retrospective cohort. We don't have a lot of those well designed high quality randomized control trial, maybe because of the difficulties as well. So to complicate the stuff in the hemodynamic in preterm infants, it can be even more difficult because of their impaired preload relative to positive pressure ventilation. The myocardium less capable of mounting up the cardiac output, which I'm going to illustrate in the next slide, and also some denervation, hypersensitivity, and skill response to catecholamine agents. We know that in those very preterm infants, especially for those SGA infants, not infrequently, they have way more collagens, they have less developed stachoplasmic reticulum. In summary, is that they have less capacities in mounting up the response in keeping the increased metabolic demands associated with the sepsis. They have a less vascular reserve and also decreased capacities in the autoregulation in the face of the sepsis. They may have some troubles in basically in the both the decreased alveolar anti-inflammatory activities, impaired alveolarization, increased pre-existing inflammations already. They may have more pulmonary vascular resistance, more PPHN, and their renals, their kidneys kind of like less developed. They may be more prone to acute kidney injury, as well as the fluid accumulation. On the other extreme is like they may have like less capacity to reabsorb fluid. They may run into the hypovolemic shock easily. So there are many unfavorable factors, hemodynamic considerations among preterm infants expressed, which may contribute to the unique hemodynamic phenotype in case of the sepsis, making the treatments management even more difficult and challenging compared with those born at term. I'm sure you'll get confused, and same as I. What should I do? So we are going to go through some of the clinical features, how the TN echo can help you. We're going to talk about the classical phenotypes and choice of medication based on the best practice and existing literatures. Clinical manifestations. Frequently, these infants may exhibit tachycardia because the heart rate is the main compensatory mechanism to maintain increased cardiac output. As I said before, the capacity to increase stroke volume is limited in infants, especially in those preterm infants. Low heart rate is a late sign. Hypotension is a late finding. In some of those classical textbooks, they say in infants, especially those are preemies, they may have to lose 30–40% of its blood volume to show some hypotension. I don't know how these numbers comes from, but I think like pretty consistently from our observation from the classical teaching, hypotension is late kind of like findings. And body temperature, don't expect the baby will have a high swinging fever because of their autonomic nervous system dysfunction. Sometimes they may show hypothermia, or even more commonly, we are being called for the what they call unstable temperature. Challenging, they will present with cold extremities, delayed capillary refills, but these are very difficult to identify, very difficult to differentiate from some of the other causes. For example, even in the acrocyanosis in the normal neonates or anemia, in the very early life, and capillary refill is a very poor predictive value and not a reliable physical findings when they compare with other when they look at those infants who are having shock as well. So in summary, it's like clinical findings are important. You always have to go to examine your baby. However, they don't have an excellent predictability as what we like to have. And this is one of the classical studies looking at the evaluation between the serum lactate as well as the SVC flow, where they try to do some kind of like correlation. You can see the dots are here are all over the place. Lactate is a kind of like, as a marker of the anaerobic respirations of the cell, and the microcirculation SVC flow is very difficult to correlate one with another. I'm sure you are getting more confused. So as we are talking about hemodynamics, we have to talk about the echo as well as some physiology. So when you first call to the bedside, the first thing, of course, you have to see the baby, examine the baby, but have a look of what's going on with the blood pressure numbers. Don't give the kind of knee-jerk response. If someone telling you about mean blood pressure is low, then give some bolus volume. If blood volume doesn't work, mean blood pressure is low below the mean gestational age, start some dopamine. I think that is not the very good way of the response. And we need to think about what are the underlying costs. We know that cardiac output is kind of like heart rate times stroke volume. Systemic vascular resistance is kind of manifestation of the neural, endocrine, and paracrine regulatory mechanism. So blood pressure is a representation of cardiac output and systemic vascular resistance. And systolic blood pressure particularly is a good marker for the cardiac output, while diastolic blood pressure is a good marker for the systemic vascular resistance. I like this table from late Reagan, published in the Seminars in Perinatology. Always use this to teach the trainees. When there is a low systolic blood pressure, it means low cardiac output. We need to think about the causes of reduced preload, whether it could be the RV dysfunction, hypovolemia, reduced contractility because of the whether it could be related to some asphyxia components, whether it could be related to as kind of like the primary cardiac dysfunction secondary to sepsis. It could sometimes be because of the frank increase in the afterload, because of the cold shock as well. Think about what are the potential pathophysiology in your baby's diastolic blood pressure. When diastolic blood pressure is low in tiny babies, worry about enlarged vascular bag is a big PDA, worry about the sepsis, systemic inflammatory response, as what we mentioned about the vasodilatation. And of course, hypovolemia can be secondary to capillary leak or the foot space, significant foot space loss. And don't forget that for those infants, we are using the heavy sedation, especially those when the baby is on the high dose of midazolam infusion, high dose of like the opioid infusions, and then together with the relative adrenal insufficiency, you will see the vasodilatation and also low vascular resistance. Think about what is the systolic component of the baby and what are the diastolic component of hypotension. Remember that the mean blood pressure is something artificial. It doesn't tell you anything about the pathophysiology. Look at the systolic and diastolic components. So of course because we are talking about TNE, so TNE is extremely important. Remember that like TNE will be able to give you some important information about what exactly the phenotype, clinical phenotype is. For example, it can tell you the left heart functions in terms of systolic and diastolic function. You can measure the ejection fraction through the MO Simpson's plan to have a good estimate of the systolic function. Through the measurement of IVRT and also the EA ratio over the mitral valve and also tissue Doppler imaging, you have a good understanding of the diastolic function as well. If you're familiar with the LV strain, those like the other techniques, you can also measure the LV strain as well. Those tracking, and you can also measure the systemic blood flow through the left ventricular output, LVO. Right heart function is also very important. Nowadays, we have way more technologies than before in terms of like traditional technologies to traditional markers, including the right ventricle output TAPC, RV fractional area shortenings to look at the systolic function, TDI of the IVS and RV free wall, as well as the speckle tracking measuring the RV string. These are all parameters allow us to quantify the systolic and the diastolic function. PDA and as well as the atrial shunting are also very important to tell us what exactly is going on in terms of the relatively systolic, relatively systemic to the pulmonary pressures, assessment of P pressures. We can also use the tricuspid regurgitation jack if the RV function is reasonable. Septal curvature can also tell us, like the second scenario with a lot of the paradoxical septal movement, you know that the pulmonary pressure is a suprasystemic. You can measure the LV eccentricity index from the parasol short axis view. You can look at the P Doppler waveform to see if there's any mid-systolic lodging. RVET to time to peak velocity ratio is also very helpful. If it is more than 4, it likely signifies significant pulmonary pressure. And organ perfusion is important equally. Like look at the Doppler patterns of the celiac artery, superior mesenteric artery, middle cerebral artery, anterior cerebral artery. So these are the kind of like the kind of like basic stuff that will be helpful for us to establish whether this is kind of like good heart functions, but high cardiac output, but low blood pressure, whether it is likely because of the low systemic vascular resistance, or the myocardial function is really bad. We need to give some medication to support the inotrope to support the ventricular dysfunction. Or it may also give us some hints where how bad is the pulmonary pressure, how are we going to support the right ventricle, or we need to start some pulmonary vasodilators, which will be a important aspects in the treatment for the neonatal septic shock. I'll just go through a few slides of the basic stuff that probably you are already pretty familiar with, and then we'll go back to our scenarios. For those with the pretty poor myocardial dysfunction, sometimes we'll use the dobutamine, which acts basically on the beta receptors. It's a very good medication. It will increase the cardiac output, increase the maybe increase the stroke volume is dose dependent fraction. I say maybe because of the preterm infants, but it will usually increase at least the heart rate and increase the cardiac output. It has a minimal impact on, in general, on the pulmonary pressure and also the afterload. Mirinol is a great drug. It has a selective phosphodiesterase-free inhibitors, increase myocardial contractility. It will also selectively decrease the pulmonary vascular bag, and it may have some beneficial impact on diastolic dysfunction. However, it can dramatically reduce the systemic afterload. So be very cautious if the baby has a profound low systemic blood pressure. Mirinol may not be a good drug because it can lead to a profound vasodilatation in systemic circulation. When there's a concern about the when the cardiac output is robust, but it is kind of like warm shot status, you may have to consider some medications to improve the vessel as acting as a vasopressor, which include the dopamine. People have been using a lot of dopamine. It will increase the blood pressure readily, but its impact on the ventricular output sometimes is kind of like debatable. It had the response in the neonate is variable. It may also the traditional teaching is that it may cause the renal vasodilatation in the low dose, but this has never been proven in the neonates. Be cautious that like in those populations, especially those preterm, it may increase pulmonary vascular resistance. Vasopressin mediates through the V1 receptors in vascular smooth muscles, and it is a potent vasoconstrictor that's been used in the catecholamine-resistant hypotension. It is very good in those especially for those with the hypertrophic cardiomyopathy type of the picture. In those infants with the frank sepsis born to the infants of diabetic mother, sometimes vasopressin is very, very good drug. However, it needs to the nurses may complain because the vasopressin need to run independently. It doesn't mix well with other medications. It cannot run with the TPN. So it may cause, if you have a limited vascular access, this may cause troubles. Now, epinephrine is a potent non-selective alpha agonist. It is very good medications, has been used to improve the SVR to PVR ratio. It can improve the, especially the vasomotor tone well. It may also be really helpful in those with the PPHN. But the advantage is like norepinephrine can run with epinephrine, dopamine, and also the TPNs, so that it will bring less pressure on the need for the number of the vascular lumens. One of those small studies published in published a couple of years ago, not a small study, it's very important, yet a pilot study published from the Texas in Journal Pediatric year 2015. And then people are looking at the vasopressin versus dopamine for treatment of the hypotension. In this pilot study, they looked at the 20 extremely low birth weights, less than 30 weeks and less than 24 hours. What they found is that the vasopressin group received fewer doses of surfactant, had lower PaCO2 values, and were less tachycardic. So this basically kind of like give us some good ideas about like vasopressins can be a reasonable option in those like infants with the significant hypotension. And people have to try to look at some dopamine versus norepinephrine for sepsis-related hypotension. The studies published from the Mount Sinai group in the Toronto, they look at those 35 weeks with who received dopamine versus dopamine or norepinephrine. They include those infants with the culture-proven sepsis as well as those clinical sepsis. They include 156 infants with around 2/3 receiving dopamine and 1/3 receiving the norepinephrine. In those propensity score, what they have found, matched studies, what they have found is that like for those who are basically receiving norepinephrines, they may have some advantage in terms of their pre-discharge mortality or significant neurodevelopmental impairment as well. So this with this kind of like study, and then right now we are doing kind of like the clinical comparative effective research across the country, looking at the outcome associated with dopamine versus norepinephrine in the sepsis-related hypotension. And don't forget, there are some other medications. They both have some inotropic and vasopressin activities. Epinephrines, low dose, they may increase the myocardial contractility. High dose, it will frankly increase the systemic vascular resistance. It may also increase the pulmonary vascular resistance as well. So it may not be the ideal option in case of frank PPHN. And don't forget that it may, the epinephrine is not uncommon to cause increased lactate as well as the serum glucose, especially in those preterm infants. Steroids, we frequently use the steroid to enhance vascular responsiveness to catecholamines. It may also be useful when there is concerns about relative adrenal insufficiency as well. Don't forget, for those infants who are having RV-dependent systemic circulations, PG will be helpful as kind of like pop-up valve to maintain the circulation. As I illustrate in the scenario 2, for those infants with closed ductus, whether it is a structural or temporary or functional, when it closes, it can cause like frank deterioration in the kind of like systemic circulation. So maintaining the ductal opening by 0.01 to 0.02 micrograms per kilo will be really helpful, at least temporary, to maintain the systemic circulation. So going back to scenario 1 and 2, so what are we going to do? In the infants with the frank NEC, with distributive shock, with hypovolemic shock, I think giving the fluid response is very reasonable. Low diastolic blood pressure. So after the T and echo, what are you going to do? Some of the colleagues may choose to give the dopamine, which is not unreasonable to increase the systemic vascular resistance, especially PPHN is not a big issue. If you like to use the norepinephrine, it's also a reasonable choice. Would you use norepinephrine or would you use the vasopressin? I think you can tell me, or you can share with that in the chat box or to have further discussions. Scenario 2 is more complicated. The infants have the biventricular failure, frank PPHN. In those cases, what are we going to do? If someone feels that, oh, the baby has the hypoxic respiratory failure, they would like to use the turn on the nitric oxide, the baby will crash further because there will be further drop in the cardiac output. So in those cases, we need to give some medications to support the ventricles. Probably what will be reasonable choice will be some dobutamine, like 5 to 10 mics I remember I start the dobutamine to support the RV, and then because of the frank vascular resist tone as well, and then like after starting the dobutamine, it's also reasonable to add on some vasopressors such as the norepinephrine or vasopressins, as well to enhance the SBR to PVR ratio. Acting on the nitric oxide to reduce the RV afterload is also very reasonable after we start the medications, and nitric oxide has also been started. The baby actually turned around the corner after several days. So I think it's very important when we consider those challenging cases, neonatal sepsis, we have to ask several questions. What is the hemodynamic phenotype? Is the baby intravascular volume depleted? Short answer, yes. We may have to give the fluid, especially like in the scenario of frank NEC, frank IVH. How is the ventricular function? Is it the RV failure? Is it biventricular function? How are we going to choose the biventricles, the inotropic support? Do we need some pulmonary vasodilator? If it is a frank sepsis, if it's RV failure, or like or the RV has not failed yet, but there's a super systemic pulmonary pressure, do we need to use some systemic? Do we need to use some pulmonary vasodilators such as the nitric oxide? Do we need to start some vasopressors to help the vasomotor tone? Do we need to add on hydrocortisone? So we have to go through this kind of like mental exercise before we decide what we are going to treat. And of course, right, the general considerations, you may have to wean the ventilations, avoid over ventilation to improve the preload. You have to try to improve the ventilations before turning on the nitric oxide to kind of like optimize the impact of the nitric on the VQ mismatch. You have to choose appropriate antibiotics. So take home message. Sorry, I'm a bit over time, but like neonatal septic shock is a serious illness. Currently, there's lack of high quality evidence to guide the treatments. A lot of those studies are extrapolate from pediatric or even adult scenarios. Clinical assessment is always important, but limited kind of like informations. TN-echo can help you to manage because you will be able to have a better idea of like what is the phenotype that you're treating, and whether to follow the response to treatment. Don't forget the phenotype can also change with time. So I would encourage you to adopt an individualized approach rather than a cookbook approach, because 10-20 mils of the kilo of the bolus followed by dopamine, dobutamine, that's not going to work in every single patient. You need to have to understand the individual phenotype and provide some individualized treatment. So I think that is it for my presentation today. So questions are welcome.
Great, thank you so much, Joseph.